All right. Hey, everyone. My name is Yaja, and today we'll be talking about descent to the testes and the anterior abdominal wall's anatomy. I guess jumping right into it. We have the layers of the anterior abdominal wall. So going from superficial to deep, obviously you'll have the skin covering everything. Right below that, you have two fascial layers. So you have your superficial, more fatty layer of Camper's fascia and your deep membranous layer called Scarpa's fascia. A good way to remember this is Camper's camp outdoors, which is outside. So your Camper's fascia is more superficial or external. Below that, you then have your external and your internal oblique muscles. So what's important to know about these is, first of all, that they're lateral. They're on the sides of your abdomen, and as they come to the middle, they turn into this thing called an aponeurosis, which is just connective tissue holding it, connecting the muscles to each other. What else you need to know about this is the direction of the fibers. So your internal oblique over here, which is just deep to your external, your fibers run from sort of lateral to medial, going up. Also, I guess, superior medially or inferior laterally, whereas your external obliques are the opposite. They go lateral to medial going down. One way to remember this is if you take your hands and you put them on your chin. So chin is internal. That's the direction of your hands is the direction of the fibers. And if you put them on your groin or sex organs, that's the direction of the external obliques. Deep to that, you then have your rectus sheath, which can have an anterior posterior. It can have two parts, but essentially just more connective tissue holding everything together to keep it stable. You then have your rectus abdominis, which is this vertical muscle going up and down, also known as your six-pack area. It has these lines separating the muscle, also which are also aponeuroses, into this distinct shape that we all know. The transversus abdominis is below that, which is a horizontal, completely horizontal muscle, almost like a massive belt just going around your waist. It's really useful in increasing intra-abdominal pressure and stuff. But yeah, those fibers are running horizontal left to right. Lastly, below that, you have your transversalis fascia, yet another fascial layer providing rigidity. The organs in there are really important to your digestion, and they move around a lot because of peristalsis for digestion. So you really want everything to be nice and tight in there to keep your core stable and prevent herniations. And below that, you have your peritoneum, which, like in rest, was the pleura, and in cardio was the pericardium. It's just this double layer visceroparietal sheet or cling film like sheet protecting everything. Okay, next important thing, we'll start off with this hexagon. This is a schematic representation that's often used to describe parts of the abdomen, where pain is. So if we go through this, these top two lines are the bottom of your ribs. So your costal margins, and they form this upside down V area at the very top. These vertical lines going on either side are obviously your lateral borders of your abdomen. And at the bottom are your inguinal ligaments, which essentially go from your ASIS or your hip down to your pubic symphysis and form the bottom lower border of the abdomen. So you can then divide this up into your quadrants or your ninths. This is like right upper quadrant pain, left upper quadrant pain. As usual, the right and left are as if you're looking at someone. And this dot in the middle is the umbilicus. Now you have this arcuate line, which is essentially if you draw a line from your if you draw a line from the umbilicus down to your pubic symphysis, 1/3 down from there, you have this imaginary hypothetical horizontal line called the arcuate line. Why this is important is the layers of the abdominal wall change above it and below it. So going deep to superficial, the order that they go in changes. So to make it easy, first of all, your skin and your Camper's and Scarpa's fascia are always most superficial. Those never change. Those always have to be in the front. Also, your external oblique is always in the front. Now, if we look above the arcuate line, right? So you're thinking anything above this line, what happens is if we go deep, superficial to deep, you have your fascias, you have your external oblique, which turns into an aponeurosis and goes over your rectus abdominis. Sorry, let me give you context for this picture. This is a cross section through the anterior abdominal wall. So you have your lateral oblique muscles coming over here on the sides. As they come to the middle, they turn into this white fibrous tissue known as aponeurosis. And this is your rectus abdominis, so like your six pack that's been cut through. Okay. So your external oblique comes from the side into the middle, turns into aponeurosis, and is superficial. Above the arcuate line, your internal oblique, just deep to that, so the second layer of muscle, comes in, turns into aponeurosis, and it splits around the rectus abdominis. So you have part of your internal oblique that's anterior, then your rectus abdominis, and then part of your internal oblique that's posterior. And then you have your transversus abdominis that's behind, followed by all the other layers, your rectus sheath, your transversalis fascia, peritoneum, and then your abdominal cavity. What changes is below the arcuate line, okay? We're in this 2/3 area. What happens is your internal oblique and your transverse abdominis now are all anterior to your rectus abdominis. So your internal oblique doesn't split anymore. It just continues ahead of the rectus abdominis and your transversalis abdominis, this last muscular layer. It also continues in front. Now, why do you think this happens? If you think about this area at the very bottom, you have a lot of your important organs there. You have your bladder, you have your uterus. You don't want any penetrating injuries to be able to get through them. So you need more support in that area. So that's the way I like to think about it, is since all these muscular layers and all these aponeuroses sort of fuse together at the bottom, it's a stronger region of the abdominal wall. Okay, linea, essentially have these vertical lines. So the line running between each rectus abdominis, also like the middle of the six pack, is your linea alba. And then on either side is your linea semilunaris. Just something to know. All right. Okay, now this can be kind of confusing. So you got your anterior abdominal wall. We've seen what it's like on the outside. Now we're going to look on the inside of the anterior abdominal wall. So imagine you're sitting in the abdominal cavity looking out towards the anterior side. So where all the organs are, your intestines, your liver, you're looking out from there. So the back side. What you'll see, first of all, is you've got your peritoneum. So your parietal layer of the peritoneum is adhering to the anterior abdominal wall. And you'll see these folds or ridges on the anterior abdominal wall, which hold certain important structures. Now you've got 5 of them. If we go through them, first of all, what confused me is these words. So there's median and there's medial. The difference between that is median is sort of another word for middle. So there can only be one middle, whereas medial, anytime in anatomy, if there's something medial, it's relative. So if there's something medial, there has to be something lateral. So that's why there's two lateral, then coming towards the middle, 2 medial, and then 1 median ligament. Okay, so your median umbilical ligament, these are just things you just need to, I guess, memorize in a way. Your median umbilical ligament holds the obliterated fetal urachus or urachus, whatever. It doesn't exist anymore, but it's really important for the fetus in embryology. Then moving to the sides, you then have your medial umbilical ligaments or medial folds, and these hold your obliterated fetal umbilical arteries. So arteries that were providing vasculature during the fetal life, which have now obliterated. So there's nothing important there now. Now, lastly, your lateral folds. This is probably the most important one. This holds still functional inferior epigastric arteries. So think of the words epigastric is it's just a word to describe your abdominal region, specifically your upper abdominal region. So you have your superior and your inferior epigastric arteries, which provide blood supply to your rectus abdominis and some other layers. And so those inferior epigastric arteries are in your lateral fold. So that's something you always want to avoid in surgery to avoid bleeding. Okay, and it's also a big landmark for hernias and stuff, which is a huge topic, so we'll talk about it later. Okay, another major landmark is Hasselbalch's triangle. Now this picture can be kind of confusing. We're again looking from the inside to the outside. This is medial, this is lateral, superior, inferior. You have this vertical muscle going up and down, which is your rectus abdominis. So we're on the right side, lateral to the right rectus abdominis, near the bottom. So I would say this is around your ASIS area or your hip area. So between the right side of your six pack and the hip, that region. Obviously it's bilateral as well, but for this region, it's on the right side. You got this triangle region highlighted in pink, and it's important because it's a weakness in the anterior abdominal wall. What that means is as you age, as the muscle layers weaken, there's chance for that wall to give out and for intestinal contents to protrude out, also known as a hernia. Now, what we need to know about this is the borders. So with the triangle here, remember this side is medial, this side is lateral. So your medial border, as you can see, is the rectus abdominis, or specifically the lateral border of the rectus abdominis. Your inferior border is your inguinal ligament, which is running from your ASIS down to your pubic symphysis. And your lateral or superior border, depending on how you see it, is your inferior epigastric vessels. So this is the direction that the inferior epigastric vessels go, from lateral to medial down to up. And so this is medial to the inferior epigastric vessels. You also have your deep inguinal ring here. This is going into your inguinal canal. So these inferior epigastric vessels, if a hernia is medial versus lateral, can determine what kind of hernia it is, which we'll talk about in a later video. I think it deserves its own video because it's such a long topic. Okay, this is a relatively low yield, but it's important to know, especially going into placement and stuff. You want to be able to note this on general inspection. You have incisions of the abdominal wall. Now, these aren't actually used as much nowadays because most procedures are done laparoscopically, so you just need 2 or 3 small incisions, but still good to know. You get your midline incision, or just a massive vertical line scar going from top to bottom. This is used more so in emergency procedures. You need a lot of visualization, and there's no major blood vessels or nerves because it's going down your linea alba. So there's not much risk of rupturing a vessel or something. That's a good thing and a bad thing. Why is it a bad thing? Is because there's no vascularization, it heals slower. And so there's risk of an incisional hernia. Paramedian is just to the side of a midline. It can be upper or lower. Transverse is a horizontal cut. Why do we like this? Usually is because if the patient then sits up, the scar itself doesn't fold upon itself like it would in a vertical incision. So it's less painful. But it also means if you get the anatomy wrong or imaging because of individual variation, you can end up not being able to access the part of the abdomen that you want. Some more incisions. So you got your subcostal, which is over here. It's essentially this diagonal cut under your right lower ribs. What's in this area? If you think of your anatomy, you've got your liver and your gallbladder. So your cholecystectomy or your gallbladder removal is done with this incision, or used to be done before laparoscopic. Steeple incision is basically the same thing with bilateral. So you need more space to look, and it can be used for liver transplants. And phenensteel is more of a gynecologic incision, and it's more so, I'm pretty sure it's done for like C-sections. So it's just this little V incision in the suprapubic region. Okay, testicular descent. Okay, moving on to the second half of this lecture. This can be kind of confusing. Let me get my pen. All right, so first of all, we need to understand peritoneum. You learned about it, as I said, you've got pleura, you've got your pericardium around the heart. It's sort of similar. So you've essentially got this cling film-like layer forming this hollow pouch or bag type of thing in your abdomen, and it just contains all your organs. There'll be a lot more on this later, but basically anything that's behind the peritoneum, so in this region, is known as retroperitoneal. Now, the testes in embryo, in fetal life, begins retroperitoneally. So your testes would be around here, okay? And they need to descend all the way down from here through the inguinal canal and out to the groin area. This is important to know. It starts retroperitoneal and it catches layers of the abdomen as it goes through. All right, let me get rid of all of that and let's move on. Okay, they start retroperitoneal. They descend during the 7th to the 12th week of development. Now, they descend, but it's more so like the fetus's abdomen is sort of growing, so relatively it descends. It's not actually descending that much, but it's attached to the scrotum by the gubernaculum. Amazing word. For once, they named something great. Very funny. It can also be known as the scrotal ligament, but that's boring. It exits the abdominal cavity through the inguinal canal, and what it does is it catches layers of the abdomen with it. So that means that the layers of the abdomen that we just talked about continue into the scrotum and are also the testes layers, because they, as it goes through the inguinal ring, it sort of wraps these layers around it and forms its own protective layers. So if we look at these photos, these diagrams, you've got over here, this top one is your layers of the abdomen as we learned them earlier. So in the actual abdominal region, external, internal obliques, transversus abdominis, transversalis fascia. Now between the transversalis fascia and your peritoneum is where your retroperitoneal organs are. So that is where your testes would start off in embryo. And this diagram has made a schematic inguinal canal. So these openings, so your opening in your transversalis transversus abdominis muscle forms your deep inguinal ring. And as it goes more superficial, then this defect in the external oblique muscle forms your superficial inguinal ring. That's your inguinal canal. So your testes descend through here. And as you can see here, it catches layers of the abdomen with it. So it's sort of, as it's going through the inguinal canal, layers of the abdomen come and form this, this protective layer around it. Now, as it exits the abdomen, the names of these layers change. For some reason, they just like to make it confusing, but these are things you need to know. So from superficial to deep, what was superficial in the abdomen? Your scarpa's fascia. That is now known as the dardos fascia. Same exact layer, same cells just going down, but now it's called the dardos fascia. Your external oblique turns into your external spermatic fascia. Makes sense. But then your internal oblique, it turns into your cremaster muscle for some reason. So it's called cremaster muscle. And then your transversalis fascia turns into your internal spermatic fascia. External, cremaster, internal, or ICE is one way to look at it. And then your peritoneum turns into this thing called the tunica vaginalis. What layer is missing from here is your transversus abdominis, and that doesn't get pulled down. That's the only abdominal layer that's not part of the testicular layers. Now, this confused me a lot, but I think if you walk through it, it should make sense. This thing called the bell clapper deformity. But before that, we need to understand the tunica vaginalis. So let me get my pen again. Hopefully this works. Okay, so you have your peritoneum. This is the bottom of the peritoneum, and your testes are coming down, attached to the gubernaculum, right? This is anterior, this is posterior. Now, your tunica vaginalis is what the peritoneum is called, and it first becomes a processus vaginalis, which is open, and then it closes off and becomes a tunica vaginalis. So the way this forms is as the testes are moving down here, the peritoneum comes down with it, but instead of going around it, instead of forming a layer around the testes, it sort of attaches to the front and it gets pulled down like this. I hope that makes sense. And it sort of forms this pouch going up, and it sticks to the anterior side of the testes like this. And then back up in the abdomen, it's your peritoneum. So your tunica vaginalis, your testes are not actually inside the tunica vaginalis, it's just behind it. And it attaches like this. Now, what can go wrong is if the tunica vaginalis, instead of attaching just to this anterior part, if it then attaches all the way around it, and it has this high attachment on the posterior side. Now over here, the tunica vaginalis is helping the testes stay in this sort of oblique angle, but by attaching onto it, but when it goes all the way around, there's nothing anchoring the testes now, and they can sort of go horizontal and lie horizontal. And it's horrible to think about, but when it's lying horizontal, it has a lot more freedom of movement because doesn't have this strong attachment. And so the testes can sort of twist inside, and that can cut off the blood supply, which is known as testicular torsion, rapid onset, suprapubic testicular pain. And that's a medical emergency, and they need to be rushed off to surgery because the testes have really short lifespan if they lose their blood supply. I think it's only 6 hours, so that immediately needs to go to surgery and get fixed. It's known as bell clapper's deformity. It's a congenital deformity where the tunica vaginalis attaches too high on the posterior side, leaving the testes free to rotate on the inside and get torsion. I think that is about all I have for you today. I think I've covered everything. All right. Hernias would be in this lecture, but I think they deserve a topic of their own just because there's so many niche details about it you need to know, and it's examined so often. So I'll make a whole different video on that. And that's all. Thanks for listening. Bye bye.